que manda.
Yes. The president of SONAP is not present today. The president of the SONAP, Dr. Vega, is not present today. Then it's a pleasure for the Association of Neurosurgeons of São Paulo State to have Dr. Ian Dunn in our meeting today. Dr. Borba, please.
Okay. It's a great pleasure to be here again. Al-Meftys series is a great success around the world. Many countries watch this webinar series. You know, Dr. Dunn, Dr. Al-Meftys, Professor Rivas, I just arrived from the Mexican Congress in Cancun. See? And I am seeing some changing in the management of meningioma. I'm seeing that the people start to open the mind in the treatment of meningioma. People start to learn and to want to understand the treatment of meningioma. And it is more than surgery, more than radiosurgery. There are so many things, so many questions, and few answers. I think no more than Professor Dunn, Linda B, under the umbrella of Professor Osama Al-Meftys, to help us to answer some questions and make a big brainstorm in our mind about the treatment of meningioma. And I'd like to Marcio Rassi introduce our speaker, Professor Dunn, from Boston, now in the Oklahoma City, the chairman of the University of Oklahoma. Marcio, please go ahead.
Thank you. No, it's a great pleasure to have Dr. Dunn here with us today. I know he's in the middle of a flight, so thank you for making room for us and being present here today. And it's a great pleasure to invite him to talk about what is beyond the treatment of meningiomas. Dr. Ian Dunn is the chair of the Department of Neurosurgery at the University of Oklahoma College of Medicine. And he's, as Dr. Borba said, he's one of Dr. Al-Meftys' best fellows and has all the philosophy on the meningiomas treatment that we all like to hear about and follow. Please, Dr. Dunn.
Well, Professor Borba and Marcio and Dr. Al-Meftys and everybody, thank you very much. I'm going to share my screen here. And I promise this is not only, this is not going to not be about surgery. I promise you that, or else everyone's going to turn their cameras off. Okay. So the title I was given by Professor Borba was meningioma beyond surgery and radiation. But what I'd like to do is discuss that, but also make the point that surgeons really are the ones who understand meningioma the best. And so really, one thing we've all learned from Professor Al-Meftys is following your patients, seeing what you see in the operating room, seeing what you uncover in the operating room is the path to understanding the biology and to inquiring about the biology. So I want to talk a little bit about the past, the present, and the future of meningioma, and weave surgery into this, and give you just one still junior surgeon's perspective on how we've gotten to where we are. It's not vetted by anybody. It has not been run by Dr. Al-Meftys. So just bear with me. And this is really dedicated to my mentor and friend, Professor Al-Meftys. This was taken during my fellowship year with him. And greetings from to all of you from Oklahoma City. And very close to the place that really stimulated and began and kindled my interest in serious microsurgery and a serious scholarship around meningioma, which was Little Rock, where I was fortunate enough to train not only with Professor Al-Meftys, but to work with Professor Yazergil also. So that was an incredibly formative year for me, and those relationships remain. I want to talk briefly about the early history, talk about some critical tools and events that just from my perspective, as I mature in the meningioma field, talk about this, what I call, it's almost a mythologic or heroic age of meningioma surgery that was present and died and is now back again in many ways. And really then talk to you about what I and Linda's on the call, Professor Al-Meftys and others very much view as the next era. And the one thing I really want to make substantiate and make a pitch for is that we really have to, as neurosurgeons, lead the way in the understanding of meningioma. And I think one of the things that's changed dramatically over the last 5 years is that non-neurosurgeons really are beginning to, in some ways, try to lead the field. And no one is better positioned to reclaim that spot than neurosurgical meningioma scholars in many ways. But if you say, who are the giants of meningioma scholarship, it is not a stretch to say, really, it's almost bookended by Harvey Cushing and Professor Al-Meftys. And I love this shot, these two pictures. You can imagine Dr. Al-Meftys at the podium making an impassioned plea to not use the gamma knife and to reclaim and remember the principles of microsurgery. And I love this picture of Professor Cushing, the quintessential surgeon scientist in many ways. And it's really almost cosmic that both of these, the canonization of meningioma as a concept, as a disease entity by Eisenhardt and Cushing, was really done at the hospital at which Professor Al-Meftys practices today. And it's an incredible and beautiful coincidence. But I want to show this slide. And if you haven't read that monograph, this meningioma monograph, it's really worth reading. It's an incredibly prescient and advanced view of a tumor, almost 100 years ago now. But this is the first classification scheme. And we'll talk about this a little bit later in the talk, classification scheme of meningiomas. And it's not radically different from the World Health Organization classification scheme, in that it's a histologically based understanding of these tumors. The one missing ingredient is the tie to outcome in some way. So our WHO scale, as we all know, grade 1, grade 2, grade 3 are associated with different recurrence rates and survival rates and so forth. But this, nevertheless, was the introduction into how we think about meningioma. And so that's in the 1930s. And if you ask, what happened between 1938 and sort of the large giant meningioma surgeons, there was a promulgation around the world that you could do neurosurgery and that meningioma was really common. So, and obviously great work was done all over the world outside the United States. And that era between the 1930s and the microsurgical era was really probably best emblazoned by surgeons like Oliver Krona, and Al-Meftys has won that eponymous medal. And surgeons around the world, I show this just to say that this represents what was happening at that time, accumulating experience with operating on meningioma, accumulations of 200, 300 versions of different locations of meningioma around the world. And that was one era of meningioma surgery before this next era. And I show this slide because it's a great reminder to me of what things were like in the 60s. I had a patient before I left Boston, a follow-up patient who'd had surgery in the 60s, late 60s. And she had surgery in California, but she lived in Boston. She's well-to-do, wealthy individual. And just through chatting, said, why did you go to California for your surgery? And from her, not a physician, sort of generally a layperson, she was told at that time there were only 2 places you could have meningioma surgery when the surgeon was using a microscope in the United States. This is what she was told. She could go to New York New York City and have surgery from Leonard Mallis at Mount Sinai, or she could go to Southern California and have surgery from Rand and Kersey. Mallis was apparently summering in the Hamptons, which is what you did as a wealthy New Yorker, and so she went to California. But that was this era of the introduction, at least in the United States, and an example of the introduction of the microscope to neurosurgery. So you have accumulating experience with meningioma macroscopically. Now you've got trailblazing surgeons using the microscope. And these events are not connected, but I would argue that another really important event in what would come next was probably this. And again, not that these individuals were passing these papers around to each other, but you had a pediatric neurosurgeon travel to Oxford, spend a sabbatical there, and learn from Cairns and Penny Bacher, and who asked him to put together their series of meningioma. And how many single author papers do we see today? But thus was born the scale that is very much under attack in some ways, but continues to be very relevant to surgeons who think to dictate what they think the Simpson grade was in their operative note. And that was the idea that the more aggressive you were at surgery, the less likely this tumor were to recur. And this is probably the second classification scheme in meningioma up until that point. The first one was histologic based in 1938, no reference to outcome. This one is surgically based with a strong link to outcome. And so we can operate on meningiomas. There's the microscope. The more aggressive we are at surgery, the better our patients will do. And the next slide is just emblematic of what really we would think is the next age of meningioma surgery, which is this heroic age, this mythologic age where, and many more individuals can be shown here, but these were shown for a reason, that you then had individual approaches for meningioma surgery tied to individual surgeons who were intrepid enough and brave enough and fearless enough to apply knowledge from under the microscope, laboratory practice, and advance the world in how we operate in surgery. And it's interesting. One debate that more junior surgeons like me have with my partners and colleagues is you've got these incredible surgeons who have led the world, and lots of talk about radiation now. And are there other surgeons below the Borba level, younger, that will continue to push forward and do microsurgery? So the next few slides are just some examples from my practice where some of these approaches through modifications are still alive and well. And then what I want to do is show you a couple of cases that illustrate the main crux of this talk, was that we still have a very poor understanding of this incredible tumor that for many, many years has been thought to be homogeneous. You look at an MRI, it's all the same color. It must be the same. But we're learning more and more about meningioma today than we've ever known. And so let me just talk a little bit about some surgical cases, and then I'll transition with a couple of cases that illustrate a really important point about our failure or incomplete understanding of how these tumors behave, and then what you do with them. And Professor Borba talked about the management of meningioma. I would say it's never been more variable than it is today, partly because of incomplete understanding of what to do surgically, and then the attempt to compensate for that with a number of other non-surgical means. But these individuals and others have given rise to these and many other approaches around the skull base. So we're just going to go around the clock, and these are cases from my practice. They're mainly shown to illustrate that these approaches born from these individuals and others are still alive and well, and they're still employed all around the world, in Oklahoma, in Brazil, in Boston, and everywhere else. And I know Dr. Al-Meftys, one of his favorite approaches is the COZ. It's probably no coincidence that most of his fellows also love that approach. And I love this evolution of that. Not that these are all sequential, but from that supraorbital craniotomy flap, we'll start with the anterior fossa, to extending that to the lateral orbit, to then down to the temporal fossa, en route to the full evolution of the COZ. And this is the late Dan Piper who first authored this paper. And in truth, at least in my practice, how as we think about the science of meningioma surgery, and now in 2021, when people say science and meningioma, they automatically think about biology, but everyone on this call can probably still appreciate there's a wonderful science around meningioma surgery, how every surgery is a little bit different, how we tweak things at every operation, and no one does that more than Professor Al-Meftys. Everything is a little bit different with the appreciation and uniqueness of every case. But for me, this general area, it's generally for me based on the supraorbital flap with a keyhole at the fulcrum, extended medially or inferiorly, or down near the masseter, with or without involving the zygomatic arch. And remember that a neurosurgeon coined that keyhole, that McCarty keyhole. And here's a case that we will see in all of our practices. Now, if you go to North American skull base, you'll see it'll be in some debate room how this case is done. Is it through the nose? Is it through transcranial approach? For me, very much still and always remain transcranial. I'll just show one reason why that will always be for me personally. This is not a large tumor, not overly complicated, no retractors here on the right side. You'll see on that right side, all that stipple dura lateral to the optic nerve that is unapproachable from an endonasal approach. Now, an endonasal enthusiast will say that the undersurface of the ipsilateral optic nerve is a blind spot. We can still have access to see that and through various angulations or introduction to the endoscope or others. So to me, that's a transcranial approach for this very routine operation for everyone on this call. Another subject of a debate room in a skull-based meeting today would be a tumor like this. So bigger, a little bit more variable, straight in the midline. For me, again, this was sent to me by a neurosurgeon who was going to do this endonasally. I did this transcranially. I'm sure 99% of this audience would also do this transcranially. And I would just show a couple of points as to why this is a great transcranial operation. Although, again, many of our colleagues would argue that this would be viable. And is it best done transcranially or intranasally? As I learned from Professor Al-Meftys, I like to keep the dura on the brain, except in the areas where we need to access. So that's how I generally open the dura. And I'm going to fast forward to one point here. I think this dissection is very hard to do endonasally. If that arachnoid is very stuck, really need two-hand microdissection, bimanual microdissection technique. I find that very hard to do with very long instruments. And so this would be a very hard operation, I think, to do with very long instruments without the ability to use two microdissecting instruments together. We'll come back to this, but this is a standard path report we would get from this type of case, a grade 1 meningioma, and maybe your pathologist will add a Ki-67. And that is the way that this path report is probably reported for the majority of the world right now. This video, unfortunately, I just checked, is not going to play past that point, but that's an example of how extending that to a full COZ gives you incredible access, again, through the innovation of Al-Meftys and others. Other surgeons that have specific approaches that are still attached to them individually would be Dolenk as an example of that extradural approach that I learned. I learned modifications and variations of that from Al-Meftys, and I see Borba and Marcio and Paulo and many people on this call practicing at our laboratory courses, and that to me is a segue into the Cavern of Science that has been lost to surgery. I think everybody would agree for many years. It has been deemed an unnavigable space for so many years. And I would argue it's probably coming back. For me, very simply, as still a maturing surgeon, for me, the pathology and the consistency matters. So especially for meningioma, if it's very firm, I have less success in the Cavern of Science than when the tumor is softer and the cranial nerves are easier to dissect. I think something like a chondrosarcoma, at least in my practice, is a perfect case for these extradural approaches. You'll see V3, GSPN, and that peeling that we talk about that I learned really in that one critical year for me with Professor Al-Meftys. So these approaches in the right hands are still alive and well. And so again, another example of a surgeon in that era that was so important to the development of meningioma surgery, that had a specific region, a specific approach attached to an individual. That how do you approach the posterior fossa from the middle fossa? And this video, I think, unfortunately, is not going to play. And I'm sorry about that, but an example that those approaches are still alive and well. I employ them in my practice. I know many of you do as well. And here's an example of that corridor you can create if you have the right understanding of the anatomy, and you have this beautiful access point to pathology that bridges the posterior and the middle fossa. I wanted to acknowledge the late Bernard Georges in yet another almost surgeon approach link that will remain in perpetuity. That is, how do you see ventral to the brainstem, and what bony corridor can you remove to facilitate your view? And that's the it's now called many different things, but we to honor Dr. Al-Meftys, it really is a transcondylar approach, and the idea that you can reach that ventrolateral brainstem by being aggressive laterally. This is from our lab here at the University of Oklahoma, and this is a version of what I employ in the operating room that I've seen Professor Borba do many times in the lab and operate on many times with Dr. Al-Meftys. A multi-layer scalp is one direction, and variations on the muscle layers are taken in a different direction. It just so turns out in Oklahoma, the patients they're big people out here, and so being able to mobilize muscle and scalp in different directions allows your hands to be much more ergonomically positioned to practice a microsurgery. And so this is an example of a case for me from last year, a nearly quadriplegic patient here in Oklahoma. That you can see on that axial, that very small sliver of cervical medullary junction and medulla compressed by a foramen magnum tumor. And if you do not create room ventral in a transcondylar approach, you really have no room. That brainstem has no reserve to be compressed and retracted as many people are want to do. And so here's the left side. And for me, what I've come to understand is that I really need to see in front of the 11th nerve, or else and as Dr. Al-Meftys, we've heard him say many times, there's always a little bit more condyle you can drill in order to further anteriorly reflect the dura to get that beautiful visualization. And being able to work in front of 11 is a great guide for that extent of your drilling here. And I'll really just speed to that point here. And so here, and Borba's shown many videos like this at our courses. You should be able to look right flat along that inferior clivus and just, you're not pulling the tumor towards the brainstem. You've created room to work anteriorly, and the operation becomes beautiful, straightforward. This particular patient, I wish I had the motor evoked potentials, but she had no potentials in the beginning of the case, and sequentially actually developed back to what would one consider a normal human baseline by the end of the end of the operation. And this is the last operative case I want to show before making a point. And this is, to me, just this incredible example of the way the world was 30 years ago. That 2/3, if you looked in the literature at that time, this is from Akuba's work, essentially almost a 70% mortality rate from a clival meningioma. So not foramen magnum, not anterior middle fossa, but a clival meningioma had almost a 70% mortality rate. And this was this incredible series of papers, Akuba, and of course, this is so synonymous with Professor Al-Meftys, how you understand the temporal bone to unlock that petroclival corridor. And this is really from my chief resident, Kadir Erkman, was the first author on this paper with Professor Al-Meftys, but cartooning a general classical posterior petrosal approach with tentorial sectioning. And this is a case we did together in Boston of a young woman, and it's phenopitoclival meningioma. And I really, the point of this is not to show so much the video, but I really want to show the post-op MRI to make a point, which is that she did very well. and you can see the drilling that's accompanied with this approach, but you'll notice there is, unfortunately, it's a grade 1 meningioma. These are very indolent, slow-growing tumors. The biology supports that when you look further, but there is residual around in the cavern of sinus around the carotid. That gristly part of the tumor, very difficult to dissect from the carotid, and again, and to navigate in the cavern of sinus with a gristly stuck portion of that tumor. So that there's the notion of residual in a very benign meningioma. Point one. The next, I want to share this case, and I was a resident at the time, and Dr. Al-Meftys is well aware of this. There was a period of time, pretty sure it was around the world. It was definitely in Boston, where what was in style, what was popular, was what was the TikTok of that era, was the subtotal resection followed by radiation. And so very, very conservative debulking, and then that would be followed almost obligately, regardless of grade, by radiation. And so this patient had again, I was a resident at the time, had tumor in the sinus. Unfortunately, actually, the tumor could have been very safely removed there. It was occluded at the time, but that sinus portion was left, and then patient had surgery, had radiation thereafter, sorry. And then fast forward, I go to Arkansas, I come back, I'm in faculty, and then I see this patient now. We do a resection, remove all of that. And it's an atypical meningioma grade 2, some mitoses, and a number of other pathologic features from a standard WHO grade report. And we'll come back to this in a minute. And then later on, we would then do some more advanced analysis. And just remember back to your biology class, all cells have a standard complement of chromosomes, and some tumors have a very disturbed version of that. And we know now, Linda is really a strong part of that effort now, leading those efforts. We know that the more disordered that looks like, the worse it is. And Dr. Al-Meftys has done really helped pioneer that work many years ago. And here is that patient's subsequent course: resection, radiation, resection, 3 rounds of radiosurgery, resection with brachytherapy, Avastin resection, and then subsequent passing. And here, this is not to show anything technical, it's just to show the misery of those surgeries that constitute a large portion of advanced meningioma practices, unfortunately in Boston today, but probably increasingly around the world. You can see brachytherapy seeds. This is just congealed, gristly, confusion of radiation necrosis and some tumor and some dural substitutes. You can see the contralateral hemisphere and just a caking of just a number of substitutes and compounds. And those are miserable cases where, the fourth time is not the best time. As Dr. Al-Meftys always says, the first time is the best time. So I show those cases, they illustrate different points. One is there's residual, and that residual is going to be monitored forever. And the second is the case of the incurable tumor, whether it was how the patient was managed in the beginning, or was it something about the tumor that was going to lead us to this point? It's unclear. And I want to also show this case that I just saw in Oklahoma, who passed through Boston. So in 2009, the patient has this tumor. She comes to a different hospital in Boston, not the Brigham, not the house of Cushing and Al-Meftys, and now B. She goes to another hospital, and she gets cyberknifed in 2009. I see her a few months ago here in Oklahoma, and now she's got this. And so she got biopsied by an ET surgeon. It's an anaplastic meningioma, or rather anaplastic versus atypical meningioma based on a biopsy. So was this a tumor that was always going to do this? Was it born to do this, or somehow, not to fuel Dr. Al-Meftys, but somehow did radiation incite this behavior of this tumor and this life cycle of this tumor? And so that leads to the last version and a part of this talk, which is what determines recurrence in 2021. So when patients ask me that, I give them generally a sort of simple answer, which I think there are two things determine recurrence. One is how well we do the surgery. And if patients in Oklahoma, just like they do in Boston, maybe they do this in Brazil, they know about Simpson grade. They have the papers, and they have all these things. And so they come with armed with this information. But I say, how we do the surgery is important. How aggressive we are is really important still. And the second is, I generally couch it as sometimes just the way the tumor is born is important. And I call it, and we start at that high level. And again, some patients know about Googling this or Googling that. So the biology of the tumor is also really important. So just how that tumor is born is going to, in large part, dictate what happens in the future. And surgery is going to bend that curve, but if it's born to be an aggressive tumor, it's going to be a problem. So these are the two still main determinants of how these tumors behave. But even Simpson in 1957 from this paper recognized that really aggressive surgery in some cases may be inadequate. So this is a direct quote from his paper. Whether in practice, clinical recurrences are more likely to result from the intrinsic malignancy of these tumors rather than from the inadequacies of surgery is still disputable. Now, that's not to let us off the hook to say that, well, surgery isn't enough. It is to say, though, that there are some tumors that, despite incredible surgeons and great surgery, are not going to behave the way that we want, the way we want them to. And so there is the surgical error that we talked about. We gave some examples of some cases, and then there was this deep interrogation into the beginning of understanding the biology of meningioma. And the first real era, but besides some of the cytogenetics of decades ago, was around steroid receptors. And Dr. Al-Meftys was a big part of that, and many of you are aware of this. The idea that females have meningioma with a greater preponderance than males must underlie, there must be something around estrogen receptor, progesterone receptor. And so that heralded in, several full issues of JNS in the White Journal and Neurosurgical, that there must be something around the presence or expression of hormone receptors. And that search, that foray into that understanding essentially died with the failure to demonstrate that anti-hormonal therapy was effective in mitigating growth in meningioma. And that's an overstatement, but by and large, continued research and investigation into the role of estrogen and progesterone by and large stopped. And so that era, it came and it went. And I'm going to show you it's going to come back again. The next big sort of epoch or era into the biology of meningioma was around radiobiology. And we're still knee deep in that right now. And how do we use radiation today? Some people use it as a standalone treatment. It is alive and well in areas outside of hardcore surgical centers. Radiosurgery is very alive, and that is Gamma Knife, Cyber Knife, LINAC. We have 2 proton centers in Oklahoma City, so you know what that means. Or people use it as adjuvant after surgery. So how's that used? So I would argue most everybody uses it after grade 3 meningioma, and after that, it's completely random. And I would argue that there are no real data that suggests that radiation is effective in anything other than a grade 3 meningioma. We use grade 3, and even there, we use it because it's cancer. But in grade 2, all the reports are all retrospective, and as I'll show you, and as we're beginning to understand, all grade 2 tumors are not created, are not equal. And we have phase 2 trials of low-risk meningiomas and radiation now, and we have 2 randomized trials ongoing right now around the world, one based in Europe, the Rome trial, one based out of the US, that are supposed to compare in quote unquote completely resected meningiomas, is observation or post-operative radiation more effective in mitigating, in overall, in creating a survival advantage or reducing, improving progression-free survival and reducing recurrence. And so you had steroids, you had radiation, and the notion of radiobiology and radio responsiveness or lack thereof. And now we're in this incredible era that will never leave, that is here to stay forever, and that is the era of what underlies what lies beneath. And if you say, what would Cushing write about today, in addition to surgical drawings and surgery, it would really be around what constitutes a meningioma. And that really probably has been a big gap in our field, one that Dr. Al-Meftys, although he's known as the quintessential surgeon, the other chapter of Al-Meftys really has been as a meningioma scientist, and cytogenetics, hormone receptors. He's contributed to all of those in many different ways. But our understanding of meningioma, the biology, should not be abdicated to oncologists and neurologists and basic scientists. Neurosurgeons really have to own this and embrace these concepts. And I want to go back to a little bit about how we classify meningioma today and look a little deeper and just agree with you how inadequate, through no one's fault, these current classification systems are in allowing us to understand how our tumors behave. Just look at grade 1, for instance, that we all know or we all think are as benign. You could have 0 mitoses in the specimen that's analyzed. You can have 3 mitoses in that specimen and still be called a grade 1. And that can't be the same, just intuitively. Those can't be the same. You can have 0 atypical features or fewer than 3. And again, those tumors can't be the same, just intuitively. And work from Helen Shee and others have shown that atypical feature part of the pathology report that's not listed by a pathologist, that actually means something. So every additional atypical feature does confer an additional risk of recurrence in the grade 1 population. So each atypical feature adds cumulatively to recurrence risk. And I think you would all agree, grade 2 is an even broader kind of wastebasket of meningioma. So is a tumor with 4 mitoses the same as 19? 3 features, does a tumor with 3 atypical features, is that the same as one with 5? Are those all the same? And I think we just intuitively, that is probably our widest bin of meningiomas and are likely our most heterogeneously behaving. So really what we have is this histology is likely just the tip of the iceberg, and it's going to be so many other predictive factors that are really going to be the bulk of the iceberg in our understanding of these tumors. And something I'll say again and again in this talk is it's not great surgical video, but we have to understand, we have to lead the understanding of meningioma as neurosurgeons. So to these pathologic features in your path reports that you get a few days after surgery, you're going to see more and more of this, and chromosomal alterations, methylation, mutational, this, and probably more. And as I'll show in subsequent slides, it's going to deeply inform how we think about meningioma. I want to just speed through a couple of concepts here. And this, again, Al-Meftys really has a heavy signature in this landscape, and Linda B is doing great work in this space, and I've been part of that in different ways. Again, back to your basic biology class, all cells have a chromosomal complement. Meningioma cells are no different. The more aggressive as you ascend in grade, the more variable and disturbed that looks. And so we get now, here in Oklahoma, Boston does it, many places do. In addition to a standard path report, we actually get a chromosomal microwave report. And we're increasingly seeing things like this. Well, we have grade 1 histology, but then we get this chromosomal report back a couple weeks later. It says, well, this grade 1 meningioma actually looks like a grade 2 based on the chromosomal profile. So clearly, the true fingerprint of the tumor is much different than just that tip of the iceberg histologic appearance that we see. And there's just a really, probably an infidelity between your molecular profile, and this is one example of that, and your histologic profile. And a great radiation oncologist, Dale Iser, Linda was part of this, I was part of this work, showed a few years ago that if you just look at meningiomas and just count up how many disturbed chromosomal regions your tumors have, it's incredibly predictive of recurrence, actually independent of the grade of the tumor or extent of resection. If you look at grade 1 meningiomas that go on to recur, if you do that chromosomal profiling, the ones that have gone on to recur initially in the initial resection had much more disturbed chromosomal profiles. They were disturbed from the beginning, despite histologically being grade 1. And this is Al-Meftys really copyrighted this concept around wolf in sheep's clothing, but clearly increased chromosomal changes in these first resections suggest more aggressive behavior. And this, I love this 1-14-22 triad. You know, what's new is really been done in many ways. This was a great paper from Al-Meftys group years ago in Arkansas, who even then highlighted this particularly malevolent triad of loss of 1, 14, and 22. And that really is associated with particularly aggressive behavior. And this is a terrific paper from Linda was the senior author, Joe Driver, Brigham resident. I was participating in this, but these molecular features, they really mean something. So if you look at a scoring system they developed, a great scoring system, just taking some of these molecular features, these copy number of these chromosomal alterations, add in mitoses and a few other molecular features. If you come up with an amalgamated score, that information is more predictive than WHO grading in overall survival. And this is such a powerful figure that if you look at the molecular features, and that's on the right side of the screen, it's called integrated class. And if you look at the WHO grade here, you can see if you try and correlate, well, does a molecular grade 1 look like a histologic grade 1? Not always. And look at the grade 2 category. Some look like grade 1, some look like grade 2, some look like grade 3. And how many times in your practices have you thought to yourself, well, this grade 1 seems a little more aggressive than usual, or this grade 2 is acting really benignly? It's clearly because we haven't been looking at the correct fingerprint to really unlock true behavior of these tumors. And here is an example in my personal practice. Here's an atypical meningioma, grade 2. MIB1 is 2%. Here's a atypical meningioma, grade 2. MIB1 is 7%. One has a monosomia of 22, which is exactly like a grade 1 would show. And one has this lethal triad of the 1, 14, and 22 loss. So these just aren't histologically, they look pretty similar, but molecularly, the true heart of the tumor is very different. It is very different. And there's some, I'm going to just have one slide on this. And this really, the idea that not looking at the genetics, but looking at how some of the genome is packaged by looking at methylation and other, I'm not going to spend too much time on this, is incredibly predictive. And the Toronto groups from Germany and others have come up with incredibly powerful ways. And look at these curves here. I mean, incredibly powerful. That if you look at methylation, it groups meningiomas into different categories that are very predictive of survival. So look at these first three on the left; they look pretty flat, and on the right, those methylation subclasses are very, very prone to recur. And Dr. Zaidi's group on the far right, if you analyze every meningioma through every genomic and epigenomic means known to mankind, it can predict incredibly powerfully how meningiomas will behave in time. This is really important information that all of us should know, is that we know meningiomas have been the NF2 tumor for a long time. And if we just look at the mutations, that is individual gene level, so much progress has been made in the last 7 years as to what the other 50% or 60% of meningiomas look like that don't have NF2 alterations. And this is an increasingly complicated figure. And I'm not going to linger too long on this slide, other than just to say, it's really good for all of us to know that the grade 1 meningioma is an increasingly complicated tumor as defined by various genes that are altered. And two that in particular that have received a lot of attention nationally and internationally have been these two here, and I won't linger too much on these, SMooth and an AKT1. The reason is they're the subject of a large clinical trial, that if meningiomas are recurring or progressing in higher grades, that perhaps and if they harbor those specific mutations, that you could consider a clinical trial enrollment if you're running out of options. An interesting note about that is, we tend to think of looking for, or cancer doctors or oncologists, our colleagues tend to think about mutations as things to target with treatments, but they're also natural history informants. So grade 1 meningiomas, olfactory group meningiomas, they're grade 1 that harbor a SMooth mutation are much more likely to recur. And when tumors have AKT or SMooth mutations, are 2/3 of the time going to be at the skull base. And so there's also natural history information to know around those tumors. And again, these molecular footprints also inform behavior. We talked about chromosomal alterations, but if your path report is very sophisticated and spits out a number of mutations that are altered, pay attention to that, because that also has natural history information. As you can see here, each of these individual mutations alone is associated with specific behaviors controlled for grade. It would be great if targetable mutations existed in higher grade meningiomas that can be so difficult to manage in the recurrent setting. And unfortunately, this beautiful montage does not exist necessarily in the higher grade landscape. What is interesting is that, and this is work Linda and I did together, and my brother, actually, who's a neurosurgeon, was involved in as well, is that just the sheer number of mutations is much higher in higher grade meningiomas compared to lower grade grade 1 meningiomas. So this is just number of mutations on the y-axis, and a number of tumors that for which this information exists on the x-axis. And there's just more mutations in more aggressive tumors. And Gavin, my brother, helped us understand that those mutations are also more likely potentially to elicit an immune response when they're present. So that's also interesting information. I'll show a case of that. And I think it's also really important to know that there are mutations that when they're present in your pathology report do predict much more aggressive behavior. And I'll show you the next few slides why it's important to know this. If your path report says you have a TERT mutation, you should pay attention. That tumor is going to behave much more aggressively. And that can be present in a grade 1 tumor. If your tumor loses BAP1, or especially down here at the bottom, CDKN2A or B, and I'll show that in a second, those are going to behave much more aggressively than a standard tumor. And this is a work that Linda led and that we published a couple of years ago, that in a perfect world, perhaps there would be some relationship between the molecular profile of a tumor as it recurs. And it turns out from a mutation standpoint that that's not really the case. So it's a very almost that family tree is not as related as you would hope. And the third recurrence may not look like the first recurrence, and so forth. All this molecular information is no longer just the subject of great papers that are published in literature. It's now really being incorporated into the World Health Organization way we understand meningioma. So like it or not, this information is here to stay. And so this is a direct a paragraph I lifted from their publication just a couple of months ago. They're acknowledging now and really incorporating the understanding of this information in WHO classification. And there's even an understanding now and a sort of a soft suggestion. You could, if your path report says there's a KLF4 and a TRAP7 mutation, for instance, that's automatically going to be listed as a secretory meningioma. If a tumor has a SMARC-E1, and I'm not going to go gene by gene, but that's going to be good enough for a specific clear cell meningioma. What I think is most interesting is if the tumor has CDKN2A beer loss or a TERT mutation, that will be considered and can be treated and managed as if it's a grade 3 meningioma. And so again, it's really important for us as surgeons to understand what this information is now. It's going to be baked into the World Health Organization and likely recurrent iterations going forward. We did a really simple analysis here in Oklahoma. We took a series of 150 tumors, 128 of which were grade 1 meningiomas. And we had this chromosomal information on 128 of them. And we had information on these, and we cherry picked these specific genes, the ones that are high risk genes that I just showed you, BAP1, CDKN2A and B, and TERT. And we said of grade 1 meningiomas that we think are benign, that 99% of the world is happy that it's a grade 1 meningioma. Do any of those have high risk molecular features? And it turns out that at least in our single institutional series, and many have done this in different ways, almost 30% of those tumors had either chromosomal profiles that were more consistently found in higher grade tumors or had one of these mutations. And so that to us, we found that a really compelling finding, that a grade 1, a quote unquote benign tumor, that almost a third really were wolves in sheep's clothing. I mentioned that my brother helped us understand that some of these higher grade meningiomas not only have more mutations, but some of them may be more likely to elicit an immune response. And this I would call sort of a Hail Mary effort. And Linda and David Reardon and others are helping understand this on a greater number of patients. But in really select instances where there's specific genetic contexts, immunotherapy may be, and that's a really soft maybe, may be effective in really surgically refractory patients who have really received nearly every other treatment modality. But that's, I think, increasing experience with using the immune system to fight meningioma is helping us understand that that will only likely be effective in a really small quarter of patients. We discussed that steroids have sort of been shelved for many years, but they are coming back again in a major way. This paper didn't receive a whole lot of attention, but I thought it was incredible, which is just like we know that radiation, which is something that is delivered outside the body, can alter the way that the genetics or genomics of an individual or of a cell. This is an example that's showing that steroids can also do something similar, that progestin as a steroid, as an agonist, can inform or change a molecular landscape. So Calmarides in France took a number of women who took progestin agonists, and they sequenced those patients and showed that their mutational profile was very different from those who had not ingested progestin. So there is something to the steroid-induced landscape for sure. And so I modified a figure that we had in a paper that we had published in Boston that, 2021, what do most people think about meningioma? And this is from the artistic mind of Linda. We think about, do we observe it? And I'd say the community at large thinks about, or do we treat it? And we discuss all these different options, whether patient surgery, radiation. Then we get a pathology report if we operate, and we use the pathology, this Ki-67 and grade to consider adjuvant therapy or just interval follow-up, and we then we watch our patients behave. What's going to happen in time is that, first of all, what we didn't discuss is we're going to get lots of information before surgery or any treatment even happens. There'll be non-invasive ways of analyzing genetic information from the bloodstream. We will sometimes understand that information from an MRI. We'll then be faced with the same decisions. And then to that pathology report will be an incredibly layered set of information that we'll get over time. Not only some genetic information, we'll get epigenetic information, we'll get immune profile, we'll get an ever more complicated set of information that will not only help us understand just the natural history and deepen our understanding of meningiomas, but hopefully will perhaps inform and provide and confer some novel treatment approaches truly for those meningiomas that are really, really challenging to only manage surgically. Unfortunately, some of those patients will recur, and that cycle will begin again, where non-invasive means will be used to monitor and survey meningioma, and then we will consider those observed or those radiated or those operated on. But regardless of how non-invasive some of this life cycle seems, at the core of any of this work is still going to be how we operate and the techniques we use to operate. And much of that we all owe to Professor Al-Meftys. And so with that, I really appreciate you spending your evening listening to this, and we're happy to answer any questions.
Oh, thank you, Professor Dan. Yeah. For us, that a regular surgeon in a poor country that treat meningioma and receive every day, and more you see patient has been irradiated, the patient that you do surgery and later his tumor come back. Sometimes it's difficult to understand how is the behavior of meningiomas. Let's start with Dr. Al-Meftys. How are you? Where are you? Are you sleeping?
No. I wanna say a few things to start with. Ian, you remember that lady who went from Boston to California to have her surgery? If she asks me today, I'll tell her go to Oklahoma and have Dr. Dunn operate you. And that's one. To Dr. Borba, you remember you're coming back from Mexico?
Yeah.
attending the meeting, and
Yeah.
you're having a new hope because
I know.
the people, great surgeon coming back to do meningiomas. You're right.
Yes,
You heard Dr. Dunn.
Yeah.
And you saw his videos. And the third one, I always believe that neurosurgeon has to be more than cutter. I always believe that we should maintain what Cushing really established, the clinical surgeon, the scientist surgeon, or the surgeon scientist. And that's a breed becoming rarer and rarer and rarer and rarer. So you just heard a lecture from one of the rare breed, which is truly a surgeon scientist. So Ian, thank you so much, and can't thank you enough for all of this. It's a beautiful lecture, beautiful surgery, and raise all the questions we have. So I will leave the great audience here to ask you.
May I start here with one question after to Professor Dunn and for
Hey, thank you, Dr. Al-Meftys. Sorry, I'm on like a second delay here. Thank you, Dr. Al-Meftys.
You're very welcome.
to Dr. Dunn, to Professor Dunn, and to the great Linda B. We know that several patients with leukemia were treated with radiation, whole brain radiation, prophylactic, during many, many years. I don't know if they are doing now. They're not doing too much now. We know that the people that came after the Second War from Europe to Israel were treated with very low doses of radiation to tinea captis. Okay? And these two ways to treat different pathologies make radiation-induced meningioma. That you know that the behavior is terrible. Sometimes they call grade 1, but you remove, you come back, you remove, you come back. But when I ask you, for you and for Linda and for all the panelists, what's the base to treat a tumor that you know that this tumor can be induced by radiation? Professor Dunn.
Well, so you know, outside of the
Biological.
outside of the bastions of Brazil and Boston, what a lot of people are doing is they are radiating the radiation-induced meningioma. I don't know if you see that in Brazil, but we see that all the time. 6 gamma knives to 6 different tumors that were wrought that actually came to life because of radiation. The other interesting observation, Professor Borba, is if someone gets whole brain radiation, theoretically the dose is distributed fairly evenly across the meninges. And some will show up and they have 3 small radiation-induced meningiomas, and 2 of them are larger. And the 3 will stay quiet for the duration of observation. And only 1 of them grows. And so that's just the random genomic disruption that radiation induces. But certainly I'd be interested in what others do, but I don't personally manage them really much different than a non-radiated induced meningiomas. But I try and, if something's growing slowly and we'll understand we'll have to operate at some point, try and maybe drag that out a little bit. But that's what we've been doing.
Linda B, where are you? In the
I'm
airport.
on board a plane.
Oh my God.
But I completely agree, and it was such a gorgeous, inspirational talk as always from my mentor and friend, Dr. Dunn. With regards to radiation-induced meningiomas, recently we've taken a keen look at our small series of 70 cases. And one of the interesting things is that, probably not surprisingly, more than half of them are grade 2 or grade 3. Amongst those that are grade 1, about 60% are what we call molecularly integrated higher grade. And amongst the 40% that are integrated grade 1, molecularly grade 1, and histologically grade 1, still more than half of those have chromosome 1p loss. So certainly, as everyone, including Dr. Al-Meftys, highlighted, they're more aggressive. And I would say, exactly as Dr. Dunn said, the biggest thing that has taught me is one might think that if they are more aggressive, that one should be more proactive in treating them. But I actually take the opposite philosophy, that because they tend to be more often atypical and aggressive, and these folks are 20, 30 years of age, and they live, that perhaps we should watch them the longer the better, short of becoming meningomatosis in some ways, because they, some of these patients have 10 surgeries by the time that they're 40, and skin flaps and other such sequelae of our treatment interventions. And so I think stretching out the cumulative tools in the armamentarium for the anticipated lifespan of the patient is an important strategy.
Great. Dr. Gabriel Vargas, you want to say something? After when I ask Professor Ribas. Gabriel, please go ahead.
Yes, thank you for that excellent talk. I think that one of the problems for us in Latin America, in some places, for example, in my city, is that still we are not able to do all that molecular studies. So I have one question. All the other studies that we have right now are going to be something that we can maybe treat so many meningiomas with drugs or something like that. Do you think that we're going in that way, that treat some meningiomas with some kind of drug or something like that? Because I think that still we need to do surgery, as you show, the best surgery that we can. And of course, we need to use that classifications for prognosis. But do you think that it's time to think that we have some kind of medication or something like that in order to treat meningiomas?
First of all, congratulations on the goal that was scored. We saw your video.
They say no goal. There was a hand, so they say no.
Waved off that. Okay, that's sad. I think that's a great question. Actually, that's why I particularly and Linda and others have been so interested in just that chromosomal information. It's obtained so often for other tumors like gliomas, when people are looking for 1P and 19Q, that it's become a much, a lot of companies around, or provide those services commercially, and so we've gotten it just paid for by the hospital, and it's become really for a lot of U.S. centers, even outside of the really big cities, it's become much easier to get. So I really like that information because it's much more obtainable for most other people. So that's one point, and the second is, I think all this information is, I'd say, where it's probably most relevant is understanding the behavior of tumors and predicting natural history, probably many years off from having a lot of therapeutic or drug relevance. The only, there was that slide, there is a clinical trial that's going on to target a couple of mutations, and those are present in such a small number. Those two are present in such a small number of meningiomas that it's really more of a proof of principle than something that's going to be really kind of changing what we do, I think.
Thank you. Dr. Ribas, Dr. Al-Meftys want to talk. Dr. Ribas, please. 1 second, Dr. Al-Meftys. Go ahead, Guilherme.
Okay,
Dr.
well,
Ribas,
congratulations.
about the ventilation.
Yeah, congratulations, about the lecture. And I don't know if I missed, but you mentioned ventilation. And would like to, you have an opinion about this? Here in Albert Einstein in Sao Paulo, we've been sending, we already sent a few samples of meningiomas to Heidelberg, to Andreas von Hemling. And talking to him, he thinks this methylation thing, classification will solve everything in pathology. And this is one question. What do you think about methylation? Now, I would have many questions of meningioma to a panel like Dr. Al-Meftys, yourself, Borba here. But I wanna just leave a second question, very simple question. What are your thoughts about a small meningioma convexity that gets inside the sinus? How do you manage this? What do you foresee with this patient, and how would you manage this patient?
Oh, good idea.
You have a small meningioma, seizure, for example, not to say that it was incidental. This patient had a seizure and has a very small meningioma, 2-3 centimeters, but there's an evident presence of meningioma inside the sinus. How you deal with this patient and what you foresee along the road?
Maybe I'll tackle the easier question first. Well, I think methylation is extremely powerful, and I think, and we actually, when we have, it's powerful because it's multiple excellent papers have shown its ability to predict behavior better than better than our regular WHO scale. It's also can be incredibly helpful. We've sent a few samples to the NIH here, National Institute of Health. If there's some ambiguity in diagnosis, it can be very helpful in discriminating diagnoses. But I'd say a huge downside is the cost, and so few centers can do it that it's great to do, but and it's very powerful. And I think it'll be, if it's scalable in the future, if it's easy for everybody to obtain, it should be obtained. But we do not routinely do it. We can't do it. And I think most U.S. centers as well can't routinely obtain it. For the sinus meningioma, how old is your patient, Professor?
36 years old.
36, okay. And it's a seizure and it's presumably growing. Well, I think before I worked with Professor Al-Meftys, I would have not pursued as aggressive surgery. But what Al-Meftys has shown me and many others is the immediate ability to operate and do well in the sinus. So in my personal practice with a 36-year-old, I do operate on those folks, and I try and be very aggressive in the sinus to the extent that it's reasonable. And Al-Meftys has helped us understand that inside that outer layer of sinus is this endothelial layer that is like a unicorn. So when you find it, it's beautiful, and it is a second protective layer that might not represent true extravasation or extension of the tumor into the blood-filled component. So I would try surgery in most of those cases.
Okay.
After I have a case to share here the opinion of the people. Dr. Al-Meftys, please.
Your case on.
Huh?
Share what you have.
Okay. Marcio is here. Marcio is here. Martin is here. Gonzalo is here. I don't know. May I show one case here? In reality, there are two cases. Let's see here. Okay. Can you see my screen?
Yes.
Okay. How can I do this? I'm not using with Zoom now, you know? Okay, 72 years old male, operated 3 years ago, okay, with partial removal and radiation therapy, okay? Now this guy is coming with paraplegia in the lesion here and severe edema. This is radiation effect or venous congestion? One question for you. The second case is this here. 60 years old lady, female, operate 10 years ago. Partial removal, flap infection. They couldn't reconstruct the skin in very bad situation. Because of this complication, they didn't send this patient to radiation. Now, after 10 years, there is a slight growth of the tumor here and here, but appears this big vein here of collateral. Okay, in the sinus is closed. Different than the previous patient that had radiation therapy, but has no venous outflow. My question is, of what the role of radiation in the development of the new pathways to the veins in the parasagittal sinus meningioma? Because the current treatment today, we know, around the whole world, is partial removal and burn, okay, and radiation. What's the difference in these two cases? This lady developed a new collaterals because she didn't irradiate, and the old guy didn't have collateral because he was irradiated. Can be true? This is Dr. Al-Meftys. What's the role of radiation in this part? Hello? Can you hear me, Dr. Al-Meftys?
You asking me or asking Dr. Dunn?
You, Dan, and everybody.
Let's ask Al-Meftys.
No, I'm gonna leave it to Dr. Dunn.
I'm going to leave it to Dr. Al-Meftys.
No, I know. Let me finish the question here. Professor Ribas, you are saying that you have in Professor Gabriel Vargas also, you are saying that you have a low-grade meningioma. If you radiate, you lose the plasticity, as Professor Dufault say. Maybe the radiation not make the same with the veins and the collaterals in this meningioma? Who else to me? Please help me.
No radiation. I just think that maybe observation, no radiation, maybe some observation, you know, time will make some veins grow up there.
No, but everybody is, the whole world is irradiating, is doing partial removal and irradiate. It's the truth. Nobody's waiting.
Louis, Professor Borba, you're suggesting that use the word plasticity. You're suggesting that radiation somehow impedes or prevents an appropriate venous plasticity, if you will.
Yeah. No, I was thinking. I'm thinking. I don't know. It's my idea. Dr. Al-Meftys.
Yeah, Borba, this is very intriguing a question. This is no little questions. Now, we know that radiation thromboses vessels. We know that radiation get rid of an AVM. We know radiation will stenoze and close veins. So your question is really very provocative a question and provocative to think. You're not crazy. You're on something. You're crazy, but you, but,
And not this much.
but on this one, you know, it's something to think about. We're talking about radiation could affect the biology of the tumor. You're talking about radiation affecting the venous drainage of the tumor, which, yeah, with radiation is known to affect vessels and to thrombose them and to close them. And radiation is known to do the opposite too. You're getting a lot of cavernomas from radiation. So the angiogenesis part of the thrombo effect of radiation is already established. Is it really playing a role like you're asking in those parasagittal meningiomas? That's very intriguing question. I never thought of it that way. But you're Borba too. I mean, you're much more smarter than I am. I don't know. Anybody has a thought on this, or knowledge, or a theory, or? It's a very intriguing question. Gabriel, what in Colombia might have?
Well, I think that Dr. Borba play a ball on this game. And I think that the same situation that you mentioned for vascular malformations, even for gliomas that get irradiated, many times we think that irradiation is not, or radiation is not something completely perfect for the patient. The problem, Professor Borba, is what to do when we have a small piece or large piece of meningioma and we couldn't take it. And we know by biology, as Dr. Don mentioned, that the tumor is going to grow. And we were with our hands, we don't take the tumor out. So wait, maybe is going to leave that tumor grow and put the patient in problems. But of course, that radiation is not good always. And your thinking is good about the vessels. And you show two cases, one with some vein grow in a patient without radiation and the other patient without any vessels. So the thinking is good, but the problem is we're treating meningiomas that tend to grow. Interesting that Dr. Don mentioned even grade 1 meningiomas with at least 30% of changes that are going to leave that tumor to grow. And we think, we have, of course, patients that the pathology said, okay, it's grade 1, no problem. And the tumor come back. So we have no armamentarium in order to treat those kind of patients. We need to use radiation many times because we have no other options. But your thinking is good, and we need to research on that. Good thinking, Dr. Borba.
Microphone.
Oh,
Microphone.
Martin. Dr. Martin. Oh.
Yeah, so well, thank you, Dr. Dan. Happiness for excellent conference. Congratulations. And definitive of the patient, the first surgery is very important, the most important. By the grade of resection, the meningioma school base, mainly, do you indicate radiotherapy independence of the histological type and the grade of removal? What's your management in the meningioma of school base?
If it's a if it's grade 1, again, let's if it's a standard grade 1 meningioma and there's a little something around the carotid or stuck to the brainstem or something, I do not automatically radiate. I would follow that, and that's something that I learned and observed with Professor Al-Meftys. If it's grade 2 and there is a complete resection, and I'm confident in a complete resection, and I've dictated that when I look back, and the MRI shows that, I am beginning to look at some of the features we're getting from some of that analysis. So if some of those features, genetic features, look really more like a grade 1 or more indolent or benign acting, I won't do anything. If they look more aggressive and I still have a complete resection, I'm still not doing anything. I can't quite pull the trigger because I don't really know if that information is going to lead to some different outcome, and I don't want to subject the patient to radiation, even if the biology looks bad, if I've had a good surgery. If there's incomplete resection or even at a grade 2, and something I wasn't able to remove something, and there are some benign genetic features, I will watch that. If there are aggressive appearing features from the molecular analysis, I will think about radiation.
Okay.
Dr. Al-Meftys, raise the hand. Antonio, Marcio, go ahead, please. Somebody has to talk.
Oh, I could talk till the morning.
Okay.
But I want to hear Dr. Dunn's opinion about this thought, okay? And they go back to the radiation-induced meningioma, the meningioma that actually induced by radiation. Little kid has medulloblastoma, leukemia, what have you, and now we come with the radiation. All of them, forget the pathology, forget the molecular, forget the genetic, forget every feature you fall, forget Dr. B. These are all malignant meningioma, regardless what any of those parameters shows. Because I define malignant meningiomas are those meningioma that has a course, a behavior that end with death. And if you follow all of these radiation-induced meningiomas, children, and I say midnight or after midnight for Dr. Krimball, so he's not with us. But if you follow all of those meningiomas, the radiation meningiomas, long enough, they're all will recur. What recurred 1 time, 2 times, 3 times, they will all start to show one molecular after another. They're all accumulate more genetic aberration, and they were all in death. So for me, malignant meningioma definition is the course that ends with fatality, regardless of what any of those other parameters showed in the beginning. And then the category of this is number 1 is radiation-induced meningioma. No, number 1 is the one from day 1 God made or created malignant meningiomas. We know them from day 1. 2 is the radiation-induced meningioma, regardless of what you find on the first time or second time you deal with them. And the 3, obviously, and you showed the example of them, those meningiomas that's coming out from everywhere right now, which we know they were supposed to be benign in the beginning, but they took on a progressive course to malignancy and in death. What do you think about that idea that malignancy and meningioma really the behavior, the final outcome, and not what all of these parameters, and that radiation-induced meningioma is malignant meningioma no matter what?
Well, no one has more experience than you do, Professor Al-Meftys. I will say, I think on the first point, I do think that like standard, let's call it a molecular footprint, I think it would support the course of those tumors, that there was something, that's the way they were born, the non-radiation induced ones that act poorly. There's something about those tumors that when they first landed in our office, were destined to just behave differently, and likely that analysis would support that eventual behavior. As to the radiation induced, I know you've seen so many of them. I follow, there's a large number of them here in Oklahoma. We have a large children's hospital for the region. And I've been surprised that at the number that have stayed stable. But certainly the ones that I have operated on, I have had the same concerns that you've had. But some of them, not all of them, at least in the experience here, have always behaved negatively.
Marcio, please go ahead.
Yes, thank you. Thank you, Dr. Dunn. Thank you again for your nice presentation. And just, it's more like a comment and maybe a simple question to Iana. I've been working in this large cancer center here in Brazil for the past 2 years. And I've been seeing a lot of meningiomas that were radiated and then reoccurred, and then the patients were sent to radiation again, and then they end up at our hospital. And most of the times the radiation oncologist sends the patients to our clinic saying, this guy was sent to radiation, but there's still a lot of tumor here. Can you take more tumor out? And I had 2 cases last year of radiation-induced meningiomas in young patients with leukemia. One was 17 and the other was 23. They were both convexity meningiomas. I could get a good resection of the dura and the bone, and the follow-up is very short, it's just a year. So I had another case that was operated and went to my clinic this year. It was a primitive neurodermal tumor in the posterior fossa that was radiated and got a big frontal meningioma in the convexity. He was operated outside and went for a second NPN, and we're still following him. We have a lot of patients seeking our hospital. They were partially treated with partial removals or just biopsies, and that were sent to radiation. And we discuss these cases in our tumor boards every month. And we have very, very ugly cases from patients that had meningiomas when they were 15, 16, and they were radiated 4 or 5 times and partial treated. And now they have tumors coming out of their skin, and it's very ugly. My question is not really a question. It's if Dr. Dunn, in his practice, has a lot of patients that are referred to him by oncologists or radiation oncologists with the same purpose. Patients that were sent by other doctors to radiation, and the oncologists refer them to you, saying, look, this guy was sent to Gamma Knife, but there's still a lot of tumor here. Can I take this out? And if you had any cases of this radiation-induced patients that were young or kids treated for any type of cancers that get brain radiation, if you get any cases of when you did your first operations, they came out as not as grade 1, because these 2 cases that I had, they came out as grade 1. If you had any cases that came out straight at the first operation as grade 2 or something more aggressive.
For radiation-induced, yeah, certainly. I would say I've looked back through my own series, and almost between 40 to 50% were grade 2 at the outset. But interestingly, a number of those had these more benign features, so they'd been stable. We see, I think with the radiation oncologist question, it depends on, so that's like the ethical radiation oncologist, right? Is the one that could use that device and could use that tool, but knows that maybe a surgical answer is better. We see not so much doubly radiated meningiomas, we see a lot of doubly radiated acoustics. I don't know if anybody else on the call does, but one gamma knife, and then a couple years later, another gamma knife, and then refer to surgery. But Marcio, just be really nice to all those radiation physicians in that hospital that will understand what you can do for them.
They have so many cases that meningioma is not good for them. Spend so much time with meningioma. Antonio has a lot of experience also in the cancer center in Rio.
Hi, Barbara. Thank you. Congratulations, Professor Dunn. Was a nice lecture. I have a question to you. Based on our knowledge nowadays of the molecular biology and the genetic alterations, for example, if you have a parasagittal meningioma in the posterior third of the sagittal sinus with a patent sinus, and you see after the resection, you leave a small piece of tumor in the lateral wall of the sinus, because on the way you must have to reconstruct it. You leave a small piece of tumor. Then you see in the post-op that it has a very bad molecular profile and genetic alterations. We are now, based in the knowledge, authorized to go back and to perform a larger and risk surgery for those patients. What do you think about it?
I am doing that in my own practice. I almost equate it to, if you do a surgery and you even forget the molecular, but let's say you get a more severe diagnosis. Let's say that you biopsied a glioma, or at surgery you sent a frozen section. Someone told you it was a grade 2, and then your pathologist goes back and realizes, oh my gosh, it's actually a glioblastoma. I'm sure it's never happened to anybody here, but it has happened to me. I would then go back and think about more surgery, and I'm beginning to think the same way about those high-risk features. If those high-risk features appear, there's some. Now, I guess part of it depends on what I thought at surgery. If I really thought there's nothing more I could do, then maybe I would think differently. But if deep in my heart I thought, I could have done that one extra 1%. I would now, knowing this information, how predictive it can be around behavior, think about a second surgery and doing something more aggressive.
Okay, thank you.
Marcio, want to talk again?
It's just a comment about the question that Dr. Antonio just asked about the, I was just reading a couple months ago the controversies in neurosurgery, and there is a chapter on the meningiomas on the posterior third of the sinus with the patent sinus, and there were two different options, and someone was making the moderator, and that guy was, if I'm not mistaken, I think that was Kuba, I'm not sure. And the let's say one of them said just partial resection and radiation, and the other said radical resection and observation. And the third guy that was in the middle said exactly what you said, like you remove the tumor if the little piece is left behind, depending on the pathology. If it's a grade 2 or something with more aggressive features, you go back and do a radical resection. That was what they said in the controversy of neurosurgeons. So just a comment. I was reading this recently, so I remember.
Now, just wait. The veins grow again. See, if the veins grow, you can go. It's my theory now.
But no,
It's
no
the Borba
radiation.
theory. No radiation. May I share one article here? Can you see my screen? Can you see this?
Yes.
This is the paper published efficacy of stereotactic radiosurgery for radiation-induced meningioma. Look at that. Okay, maybe a lot of people is giving radiation-induced meningioma after recurrence. But what makes us more confused that this is the case to exemplify the paper. Look at this. This you can take 10 centimeters margin to remove this tumor. Okay. And the more intricate it's the authors that I just covered the names, is a very prominent group of skull-based surgeon and research guy in meningioma. I don't know how to understand what's happening today in the literature. How you can understand this?
You know, the one problem with that type of, and I'm familiar with that group and who wrote that, is that, you know, it's one thing for everyone on this call who is a real expert in meningioma to read that and then to put it down and not put that into practice, and you wouldn't do that. The problem is when that gets to some radiation oncology conference, and then someone goes to get some credits and then comes back to their community and is not in a large center like you're all at, and then begins to, I mean, that's how this stuff propagates, right? Then it seeps from one group to another, and
Like happens
becomes,
with the,
I mean, there's
like
radiation
happened with
for,
the acoustics.
yeah, radiation for 4 centimeter acoustics now, radiation for 5 centimeter mets, and it's these papers like that that say, hey, you can do this.
But for this meningioma, the example, you see,
Dr.
the illustrative
Borba,
case is crazy.
Dr. Borba showed us the miracle, but didn't tell us the name of the saints.
Yeah, Dr. Al-Meftys knows. He'll be upset if me I cannot show. No, he'll be very happy. Dr. Al-Meftys.
Dr. Borba, yeah. Is this stereotactic or observation meningioma, 1 centimeter, for example? What's we call management?
Which case? This case?
Which case?
The case that I show?
Yeah.
Radiation induced.
Stereotactic or observation? Stereotactic.
No. If you have 2 centimeters meningioma, like my finger, okay?
Yeah.
Radiation induced meningioma that you know that probably have a very bad behavior. Do the surgery and remove the whole dura if you're worried about that. No, maybe not change, but not is the example for radiation treatment. I'm trying to say this. The literature is very confused. Imagine a young guy, a resident, is starting this practice. You have a case like this. How I do now? Imagine the guy, how confused the people be. See? I don't know. I'm losing the hair, and my brain is making more difficult. Dr. Al-Meftys, what do you think? You're still here?
Well, you're putting your finger. You want me to say what you want to say.
No,
so I would say it with no hesitation. There is no place for primary radiosurgery for meningioma on the convexity. No, even if the patient was 90 years old. Radiosurgery is a volume. It's a 3 centimeter maximum, right? There was 2.5, now it's a 3, but that's all right. A 3 centimeter meningioma on the convexity, it's either totally asymptomatic, regardless of what the age, and they could be followed, or they're symptomatic and they could be removed, like you said, with the immersion, and never to worry about them, with the minimum risk that much, much lower than the radiation risk. The people do not understand that with gamma knife radiation, there is 4%, no matter what you're giving it and how much, 4% seizures. There is still 25 to 30% that white edema, they're calling it, on the MRI. You could hold the MRI of any patient radiated, and you could tell that this is radiated patient or gamma knife patient. The confusion is not confusion. It's deliberate drive to use, to sell the gamma knife treatment for those people. It's meant, it's deliberate, it's marketing. It's a pushed and shoved down the throat. And now Dr. Dunn said the most critical point. We're turning, and they're grabbing it. Meningiomas to the oncologists. And that's the worst things could ever happen, because those meningiomas gonna go directly, like this patient you showed, to the gamma knife and never have the benefit of at least the opinion of a surgeon, not the ability of the surgeon, but the opinion even. And I think that's the most, Ian, you mentioned it. This is the things which neurosurgeons need to wake up for the benefit of the patient today and for the coming 20 years. Meningioma is a surgical disease. Need to start with the neurosurgeon. Any other treatment, it's a totally adjunctive for a desperate cases. So, yeah, there is no place for this to be given gamma knife, but unfortunately, the expert in the big centers on all of the web pages, that's what is being sold. Yeah, that's exactly what you want to say, right? I said it for you.
Okay, thank you. May I show another case? May I show another case?
Absolutely.
Oh,
Dr.
tá falando
Barba,
demais, mas fala.
how did you manage those two cases?
Which one?
The two cases you showed.
Parasagittal?
Yeah.
The old guy paraplegic, I removed. The other lady, stay just control. There is no skin, has no bone, has nothing there. Let her life. She's living okay. You see, asymptomatic. The other guy is paraplegic. I try to remove the tumor. Maybe it's malignant transformation. Let me show another thing just to make more. I went back very. Here, Dr. Al-Meftys, it's for you. Okay? Just headache.
For Dr. Dunn.
Just headache. Okay? Just headache. But compression of the brainstem or the spinal cord. Okay? No neurological deficit, but severe pain. Not about the approach. Surgery or not surgery?
Dr. Barba,
Yes,
they're
sir.
having a symposium in the memory of the great late Dr. Bernard George. And the program you probably have received. And on the program, one presentation titled Foramen Magnum Neurosurgeon Playground. So I made the presentation and titled it Foramen Magnum, How do you get out Macabre Valley? You know what macabre, right?
Yeah.
It's a French word, really. It's the horror, the fearsome, the terrible, the horror, with the little
close to
Malayan.
this Halloween time, no horror, macabre.
Yeah, macabre, exactly. There is nothing that scares me as much as I'm scared with everything, on every case, on a little things. But there is nothing that scares me as much operating around the foramen magnum. And it's not just the theoretical, it's from experience. Because just imagine your patient woke up totally paralyzed from the neck down, cannot breathe, on ventilator, and fully awake and fully comprehend and fully, the brain is fine. It's for me, it's getting out macabre. Okay,
if
I want
show
to
you,
tell everybody that foramen magnum meningioma, for me, it's the biggest concern, no matter how simple or the things goes. Okay, now, having said that, I believe that foramen magnum is very tight. So meningiomas in the foramen magnum, you may as well get them the minute you find them, because the concern of a serious complication later.
If I tell you that this patient was...
So I operate.
Okay.
As scared as I am, as I told you, as I am.
Okay. And this patient was operated by ENT.
Yeah.
And the post-op was this.
Yeah.
Now, cervical junction, cranial-cervical junction is stabilization. Unstable, unstable. How you say, Marcio? Stable.
Yeah, unstable.
See? And the tumor is there.
It's not stable. Okay. Yeah, but this is
unstable.
Like,
unstable.
This is the same problem. Where's Aldo? He's still there. This is the same problem. We're talking about radiation and the meningioma and how they're radiating. And the endoscopic and meningioma is the same story.
No, but some people does good job, Dr. Al-Meftys. The problem here that I see...
Not for meningioma. There is no good job on endoscopic meningioma.
I know. But you see that the guy that the ENT that's tried to do this, was not even, from the school of Dr. Aldo, please. Don't compare anything, cannot compare.
It doesn't matter. I love Aldo. I think he's a great surgeon. Okay. But meningioma is not their business.
I know, because I'm saying this. They did the approach anteriorly. They left the tumor, and now have this. What you are seeing in skull base, you are seeing in meningioma, the same that you are seeing in pituitary. People doing surgery without any knowledge about the pathology itself. It's the biggest problem. See? More than don't know how to do the treatment. See, not about the approach itself. They have no idea about the disease. It's very common today around the world. You see around the world many people doing many pituitary surgery without neurosurgery. Now they are doing some meningiomas without neurosurgeon. See? The team of Dr. Aldo that was here was a great guy. Aldo is a neurosurgeon together. They work together. But we are seeing around the world, Dr. Al-Meftys, a lot of ENT doing the job completely alone. And the other thing that we are seeing now around the world is the ENT working with radiation oncologists to do radiosurgery for acoustics, for radiosurgery for skull-based meningioma, for radiosurgery for whatever they want. For many of these patients has otological symptoms or rhinological symptoms. They see the patient before. And the neurosurgery has been out of the business when we should be the head of the business, no? I just want to make this point, is no more about just radiation, just behavior of the tumor. It's behavior of the people. And how confused is today the literature? How confused today is the treatment of several diseases in skull base? See, just want to say this. Meningiomas for neurosurgery, intradural approach, okay, Dr. Al-Meftys? I agree 100%, no problem. But just to make the point, if I don't say this, he'll kill me by Zoom. I will be the first guy that will be death by Zoom.
Yeah, he heard gamma knife and ENT, and he had to go off camera for a few minutes.
Borba, can I say something about the foramen magnum meningioma? Which is, can I share my screen?
Yeah, go ahead.
And I want to hear Dr. Dunn's thought. You see, your main concern, this is, I don't know from whom, I will have the better illustration, but just to bring the things. The main concern is this, the anterior spinal artery, okay? And that will really knock you totally out. I'm concentrating this time on this. There is a small perforators come out right at the junction of the basilar and vertebral artery, exactly like the perforator on the basilar tip. These are the perforator of the basilar bottom, and they go in the mid, Marcio, correct me, the mid-sulcus, but in the medulla. There is a, between the two pyramids, there is a sulcus right there, and has a perforator. And those perforator goes right there, and they're straight to the pyramidal tract in the medulla. And when they get weak, I mean, they get compromised, you get what you call Duchenne syndrome. It's the medial medullary syndrome. And Duchenne syndrome could be a little more smaller with those perforators, that you get it selectively only motor. So what happened to you during the operation, if those got involved, the SSEP is normal because those do not go to the posterior column. The motor is gone. So I think all the foramen magnum meningioma need both motor and sensory. And the thing is, the anterior spinal is the big deal but there is a perforators coming off the basilar vertebral artery, which is analogy of the basilar tip aneurysm 100%. I could stop. You buy that?
If we stop, we stop.
Do you buy it?
Dr. Dunn need to go to the airport, no?
Oh, I buy what Dr. Al-Meftys just said, and you said the monitoring. Does everyone on this call use monitoring for foramen magnum meningioma?
Oh yeah.
I didn't see.
Now I'm using monitor for carpal tunnel.
Really?
No.
Use the monitoring for gamma knife?
Yeah, maybe.
He's the owner of the device, you know.
Maybe it's a good idea. Okay. Now you are 2 hours talking here. What time is in Boston now? 4 p.m. In Oklahoma,
9 o'clock.
what time is now? Oklahoma, 9 p.m.
Oklahoma, 8 o'clock.
8 o'clock.
8 o'clock. Okay. Professor Vargas, you'll be the last question. And after
Yes,
Dr.
yes.
Dunn and Dr. Meftys close the section, that is 10 p.m. here.
Just one quick question for Dr. Al-Meftys about that meningiomas on the foramen magnum. You say that you take it out. How do you prevent the damage of that perforator that you already showed?
How will I prevent the damage? The
Yes.
intra-arachnoidal dissection. You gotta have to leave a layer of arachnoid against those perforators. Be sure they're supply and put papaverine on them too. It's exactly like basilar tip aneurysm and the perforator of basilar tip.
Thank you.
Okay, thank you. Please, Professor Dunn, thank you very, very much for 2 hours talk. You can stay 10 hours here. Meningioma. I want to make a last question for you, for Dr. Al-Meftys, and you finish the session, okay? How much money today is spent in research for meningioma, in percentage, compare with malignant gliomas? You compare how? The NIH spend more money with meningioma or for GBM?
Oh, far more on GBM.
How many people with meningioma, if you study more, you can save with new research in meningioma compare with glioblastoma, Dr. Al-Meftys? You know what I mean?
How many more
You
money?
think that if you spend more time in research, if meningioma is worth than to spend with GBM or not? Because you save more people.
Well, it's worth to spend more money, yes, more than another tumor and another sick people. You can't compare that. We're gonna take something from somebody and put it into somebody else.
I'm not saying take the money from them.
Yes.
And put more money in meningioma.
Yes, absolutely. But here what I believe, and 20 years, the Dr. Dunn will prove me wrong. A meningioma is benign tumor. the research on it has to go through paths different than the malignant tumor. Has to go through paths of the biology of this benign tumor. Now, all the research of the malignant tumor came to find a killer medicine because they're malignant. A meningioma is going to be hard to find a killer medicine because they're benign.
Maybe.
So, yeah, that's what I said. He's going to prove me wrong one day. But till then, the meningioma already had a very successful, cheap, curative treatment. And that's the beautiful surgery Dr. Dunn has shown. So the interest in meningioma today and tomorrow, the must understand me, all the research on molecular and genetic is beautiful, but the emphasis, the effort has to be into refining that surgery to have all neurosurgeon and all patients with meningioma have as beautiful surgery as Dr. Dunn showed. You got me? Okay.
But you need the research. We need the research. You to study biology, you to understand the tumor. We need to know. Maybe you can find a cabergoline to prolactinoma. You can find a cabergoline to meningioma. Maybe.
Hopefully.
Okay. Thank you. Thank you, Professor.
Thank you,
Professor
everybody.
Aziz can close the session. And thank you very, very much to everybody. 2 hours and 10 minutes online here is to be in the YouTube for many, many people around the world can watch this wonderful presentation. One of the best sessions that you have here. Thank you, sir.
Dunn,
thank you.
Thank you all very much.
Thank you.
Dunn.
Thank you. That's
Thank you.
beautiful.
Thank you.
Beautiful.
Thank you,
Thank you,
Dr.
Professor
Ian, for the
Almeftys.
nice
Thank you.
presentation.
Thank you.
Thank you, Ian.
Thank you. Thank you.
Thank you.
Okay, bye-bye.
Thank
Bye.
you.
Thank you, Professor Almeftys.
Claudio,
Thank
thank
you,
you.
everybody.
Claudio.
Bye,
I didn't
Aziz.
see Claudio. He came later.
Bye, Dr. Al-Meftys.
Thank
Oi,
you.
Cláudio, não tinha te visto aqui,
Hello.
desculpa, cara. Chegasse mais tarde. Um abraço. Tudo.
That's no problem.
Quanto foi o jogo da Colômbia?
Eu não vi.
Doctor Borba.
Quanto foi o jogo de Colômbia?
0-0, anularon el gol. Anularon el gol.
Vamos ver se Brasil gana ahora. Okay?
Brasil começou
Tú
já.
sabes, buen partido contra Brasil, ¿no?
Buen partido. Ok, tchau. Tchau,
Ei,
tchau, tchau.
Chao,
Gonçalo,
gracias.
abraço. Tchau, 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 tchau. Tchau.
Obrigado.
Tchau.